So welcome, and thanks for joining us today for our webinar, Layered Learning, Integrating Learners into Your Clinical Practice. Enseignement multiniveau, intégrer des apprenants dans votre pratique clinique. No matter what stage of your careers you're in as family medicine preceptors, successfully applying layered learning can be daunting, and even more so now as we are challenged with providing virtual care to our patients. We hope that at the end of this webinar, you will feel equipped to accept this challenge. Next slide. Our presentation today will be in English. Our slides are bilingual. If there are any French questions, they will be answered by our Francophone presenter. Next slide. So before I begin, I just would like to review some of the chat box instructions. To participate in the live chat, please log into your YouTube or Google account. Throughout the presentation, we will have several polls, and please use YouTube live chat to participate in these polls and respond to the questions. This webinar has been certified by the College of Family Physicians for one Mainpro+ credit, and that would be the live webinar. Throughout the presentation, you will note in the chat box there will be a link to an evaluation survey. Please complete this survey for direct credit entry of your Mainpro+ credits. The webinar is recorded and is eligible for non-certified credits in the self-learning category of Mainpro+. Participants may also get certified credits by completing a linking learning exercise. Next slide. We would like to acknowledge the Undergrad Executive Education Committee. Members include Dr. Maria Hubinet, Dr. Risa Freeman, Dr. Natalie Boudreau, myself, Dr. Lynn Power, and Dr. Lisa Graves, my co-presenter, Dr. George Kim, Dr. Martina Kelly, Julia Petta, and Alexandra Reynard. Next slide. So I'm Lynn Power. I'm a family physician in rural Newfoundland, and I'm the undergrad director for family medicine at Memorial University.
And I'm Lynn's co-presenter, Lisa Graves, and I'm currently a professor of family and community medicine at WMU Homer Stryker MD School of Medicine, located in Kalamazoo, Michigan, but currently also maintain active practice in the province of Ontario. Now, I do not have any conflicts of interest to declare.
And nor do I.
And we want to acknowledge that we have received in-kind support from the CFPC for assistance in this. And we actually also want to remind everyone we have no additional mitigating biases to address. Next slide. La même chose en français. Next slide, please. Next slide, please. So we wanted to start off by telling you what it is we're going to talk about. We're going to identify the challenges and benefits of hosting multi-level learners in a clinical setting. We're going to come up with some very practical strategies to help overcome the barriers to working with multi-level learners. And we're going to really very prescriptively identify some teaching techniques that you may find useful in the clinical setting for multi-level learners. Next slide. What we're really going to be talking about is what is layered learning? What are the challenges and benefits? And really, what are some very practical tips for integrating layered learners into your teaching practice that you currently have? Next slide.
So there are various terms you will often hear interchanged when reading about or researching layered learning. Some of these terms include multi-level learners and vertical integration. So multi-level learners is basically medical learners of various levels of training and possibly varying disciplines are engaged in a clinical setting at the same time. Vertical integration is teaching and learning roles are shared across all learner stages in a clinical setting. Next slide, please. So our first poll is we would like you to think about and type in the chat box. What are some examples from your clinical teaching of layered learning?
And Lynn, while our participants are completing the poll, I know that it's been interesting as we've been reflecting on layered learning, just how often we use layered learning outside of our clinical teaching, outside of our clinical teaching environments. We use it every time we take a multi-generational family vacation. We use it every time we have many generations of a family in the office together. So I think it'll be really interesting as we move through this presentation to think about how our clinical teaching really aligns with many other aspects of what it is we do as physicians.
As well, I think one of the key pieces as family doctors, we're great collaborators. And layered learning is a great opportunity to teach people about collaboration and sharing of knowledge. So we'll move to the next slide while you continue to type. So some of the features of layered learning, which we'd like to highlight, are one is that it's active learning in small groups. That may be hosting a sim session where you have a resident and a medical student and a preceptor, or perhaps other allied health like EMS. Or another important feature is to recognize that most people in the group have varying learning needs. Everybody is at different stages of learning. Sometimes people have come from different medical schools, so their experiences, even at the same level, may have been very different. It's very important to recognize the sharing of experience and knowledge and how this contributes to the benefits of layered learning, which Lisa will talk some more about. Layered learning is very negotiated, and there's lots of sharing of knowledge. And really important is the collaboration among learners and preceptors. Next slide. So why do we need to layer learners? And the first point I think is really important for me. One, the need for more placements for all learners. And my interest in this topic really stemmed from this reason. A few years ago, I was the clerkship director at Memorial University when we had a significant increase in class size. At Memorial, we have a lot of pre-clerkship and clerkship placements that are rural, and hence we needed more placements. When I approach preceptors, I frequently heard the response, well, I'd love to, but I have a resident. So then became, why can't we do both? So hence my interest was triggered in layered learning. Another really important reason why we need to layer learners is for accreditation standards. Residents need to teach in their own discipline. We as medical schools need to provide them these opportunities, and it's very important for undergraduate students to be taught by residents as well. The final reason listed there is learners benefit from near-peer teaching. And I think this is a really great way to entice learners to become teachers, to become our teachers of tomorrow. Next slide, please. So in this poll, we want you to think about where you have provided layered learning in your clinical practice. In the chat box, you can type one of your answers or many of your answers. So A, in the office, B, in the hospital, C, in an emergency room department, D, in a procedures clinic, and E, other.
And Lynn, while participants are answering the poll, I think it's been really interesting to look at the answers to our first poll, which, again, cites some of the many examples where layered learning happens. The medical student and the resident, the fellow in family medicine and the first-year resident, other healthcare professionals in terms of interprofessional learning together. And even some learners who are at the same level, we not infrequently see one learner who's a little bit further ahead than their peers. And so layering can occur even within learners who are effectively at the same level.
Mhm. And I think too, another challenge we face now is, most schools are ready to move their undergrad students back into the clinical practice. And so with the challenges we already face with providing virtual care during the COVID-19 pandemic, thinking about how we as preceptors will be able to provide layered learning in a virtual care setting is another really interesting topic. So next slide. So as we said, some of the places that layered learning can occur in a procedures clinic. So one of the places I love to layer learning is in procedures clinics. So everything from teaching the informed consent to how to prep your tray to do a procedure, to doing the procedure, to the post-procedure care counseling. So great opportunities for medical students and residents to interact and to teach each other. The ambulatory care setting is a really interesting place. The inpatient setting, emergency department, everywhere, anywhere really, you can layer learning. Being from Newfoundland, if any of you guys have had the opportunity to visit, kitchen parties are a huge thing. People like to gather in the kitchen. So in my clinic, in the center of our clinic, we have a large kitchen, and that's where chart review happens at the end of clinic. Everyone sits and we discuss, we layer our teaching, we teach each other, and we find that works really well. So anywhere layered learning can happen.
And next slide.
Mhm.
And Lynn, you're quite correct. I think the most popular answer to our question was everywhere. And that's where we were hoping that everyone would get to. I do want to acknowledge that one place that we didn't list as some of the potential options were, again, our administrative offices for those of you who have positions that involve research or leadership. So it really and truly is, there are opportunities for layered learning everywhere. So I want to take you through a little bit of the review of the literature that sort of underpins the thinking that we currently have around layered learning. Next slide. And again, there are a number of studies that Lynn and I want to draw your attention that we think might resonate with this group as you're looking for grounding what it is you do educationally and what does the evidence suggest. So in one study that was in a rural general practice, they conducted semi-structured interviews with learners, staff, and patients to look at both the benefits and challenges identified by both learners and the practice, in other words, the patients and staff themselves, for layered learning. Next slide. What this really pointed to was the real benefits that exist for learners in terms of the confidence they gain from layered learning, the sense of being part of a team, and the supportive learning environment that layered learning actually provides by learners. There's tremendous benefit in near-peer learning and having learners who are proximate to other learners in their developmental stage learn together. It focuses multi-level learners become the focus and center of learning. And it really does seem to improve the skills of our learners who are teaching, as well as their satisfaction with their teaching experience. Next slide. There are also benefits to the teachers, the preceptors, and to the practice itself. We're seeing more and more evidence that this is a time-efficient way to address multiple learners in the office. Relations with colleagues seem to improve in environments with layered learning. Morale is increased, demands seem to increase. People are happier with their practice and with the job they're doing. There is an increased sense that knowledge is being exchanged across all the layers that exist of the learners, and really a much deeper sense of a community of learning actually evolving within the practice. Next slide. There are some challenges. Many of us struggle with space and capacity. Where do we put all of the learners? There can be some learner anxiety around this. Am I going to be taught as well if my teacher is not a full-fledged physician? Can be anxiety around, will there be enough time left for patients? Will patients understand layered learners? How will they understand the difference between a resident and a fellow and a medical student? If learners are coming from not only multiple levels, but different institutions, there can be challenges related to understanding what are the curricular requirements that you need to help the learner meet when they're in your practice. Again, another challenge is what is the developmental stage of the learner? And that was wonderfully highlighted by a number of comments around the fact that the level of the learner can be very different, even if they are supposed to be at the same educational level. And again, where do we draw sort of lines around learner autonomy? How far can we let learners function autonomously in a layered learning environment? Next slide. For many individuals, our training as a teacher has not actually focused on layered learning. One of the reasons that we're focusing on this in the webinar. Although layered learning is quite common in medical education, the attending physician walking through the hospital with a team of learners behind is a common perception of what medical education looks like. Hasn't always been paralleled for those of us who teach in the outpatient setting. So that can feel challenging as a teacher, and that's one of the reasons why we want to make certain we provided you with some practical tips. Learning outcome, again, varies with program, depending on what program your learner is from, and the more programs that you have to address, the more opportunities that you have for interacting with different curricula, and in fact, different medical schools, and might I say, different health professional education schools. Next slide. So how can we overcome these challenges? Well, again, Lynn and I looked to the literature to see what factors could support layered learning. Next slide. And this comes from a paper that, again, interviewed medical students, residents, and attended faculties, again, using semi-structured interviews to actually look at the factors within the practice learning environment and teaching methods that actually supported layered learning. And some of the factors they came to that support layered learning are detailed on the next slide. Again, people who were happy in their jobs and an enjoyment that came from their practices seemed to adapt well to layered learning. A culture of teaching and that supported teaching and that was very evocative of learning in the workplace was considered supportive. Having good administrative support, adequate space and remuneration were factors, and a flexibility to actually adapt in the work environment, in the clinical environment, to the opportunities that layered learning could present, and the challenges that required some flexibility to adapt to. Next slide. In addition, and some of these start to go into the teaching methods that we'll address more robustly in a few minutes, were group tutorials, informal teaching, a parallel consulting process, using residents as teachers, the concept of teaching as a team rather than as an individual, and again, that focus on teaching across the disciplines. That again, in a layered learning, successful environment, use of some of these teaching methods was significant and important in terms of making certain that layered learning actually worked. Next slide. And one of the key principles that really has come out of looking at the literature around layered learning is really this concept of differentiated instruction. And that means being very thoughtful about where we're actually teaching and to which level of learner we're actually teaching to, so that we make certain that our teaching targets individual learners in a thoughtful way, so that we start to understand when we're addressing something that is for the medical student, is for the early healthcare professional learner, is for the resident, or is for someone who's completed their residency and is engaged in additional training. By being thoughtful about this, though, what it does do is it reduces the amount of teaching that any trainee may judge to be either over their head or boring. So by being very mindful when we're teaching layered learners of where people are at, we can actually make certain that our team of learners understands to whom we are directing the teaching and where their role fits in terms of what layer is being addressed, so that, again, they are engaged in a practice of teaching across layered learning that is more explicit than implicit. Next slide.
So before I begin this slide, I just wanted to follow up on something Lisa mentioned. And one of the struggles is when you have students from different schools. And within Canada now, a lot of the undergrad curriculums are evaluated in different ways. So one of the challenges in Newfoundland that we have is we have medical students in New Brunswick, and the New Brunswick sites also co-host the Dalhousie students. So when you put two students in a similar clinical environment, but with two different assessment models, so whether it's EPAs or clinic cards or whichever method schools use, that in itself becomes another huge challenge. So certainly there are challenges, but none of them I think are insurmountable.
And Lynn, while you were speaking, I had an opportunity to look at the comments in the chat, and I agree. There's some really great ideas about how to use the layers differently in multiple different settings, from curriculum development to in-class teaching, to again recognizing the value that interprofessional learners bring. I think there's some really, if people have not turned their attention to the chat, there's some really great ideas emerging from that.
Mm-hmm. And I think as well, the more we groom our residents to be teachers in our clinical settings, I think the bigger role they could have for us in structured activities like the PBLs that someone makes reference to in the group chat, or helping facilitate academic half days. I mean, anything to do to help groom them to become teachers, I think is great. And certainly with the constraints at a lot of university for teaching hours and things like that, it would certainly help in that way as well. And I guess a final point about a challenge which I've encountered is if you have a resident who's not engaged in this. And really, for layered learning to function really well, we certainly need our residents to be engaged and interested and be a huge part and take a real lead role in this teaching method. And as Lisa mentioned in our last slide, with layered learning, differentiated instruction is such a huge piece that we need to recognize. And there's some teaching methods that will help with differentiated instruction. Some of those teaching methods include broadening, targeting, novelty, progressive questions, which is sometimes referred to as up the ladder, student as teacher, and teaching to the top. So in the next upcoming slides, I will review each of these individually. Next slide, please. So broadening. We've probably not called it broadening, but we've all done this many times, perhaps in every single session we have with learners. Broadening is simply where we change the specifics of a case to make it more challenging, more interesting, or even perhaps to fit a certain learning objective we're trying to achieve. An example would be you have a patient who's a 35-year-old woman and has a UTI. What would your approach be to that management? So a medical student would probably explain their approach. And then you could change it and say, what if the patient was pregnant? What if the patient was 75 years old and had an indwelling catheter? If you wanted to teach about students thinking about febrile neutropenia and things, you would ask the question, what if she was on chemotherapy? How would that change your management? So really changing the specifics of a case to make it a complete new learning opportunity. Next slide, please. The second method is targeting, and targeting medical knowledge questions at specific team members based on difficulty is what this means. So you may have a 65-year-old patient who has pneumonia, and you would ask your earliest medical student, what are some clinical features of pneumonia? And your clinical clerk or your M3 who's had more clinical experience, you would ask them, what are some of the admission criteria for patients with pneumonia? So progressively, your questions are getting a little harder. The first-year resident has had more clinical experience, so you may ask them about the specific bacteria that may be associated with pneumonia in this age group, and perhaps what antibiotics they would choose. And the RT, you would go a little step further and talk about what are some potential complications of pneumonia that you should watch for.
And Lynn, I think that what's been, again, some interesting thoughts from the chat that I've been looking at is the idea of how to facilitate and observe our learners teaching as much as actually directing the layered learning teaching ourselves. And I think that one of the things that both broadening and targeting do is help us start to develop that comfort in being able to allow senior learners to do more teaching in front of us, and are particularly useful for one's particularly first dipping one's toes into the layered learning environment. So I was reflecting on that as you were speaking, how both broadening and targeting really are opportunities to develop a structure and an approach that lets us start to play around with layered learning, and again, eventually start to take a bit more of that facilitator role rather than the directed teacher role in dealing with multiple layered learners.
Absolutely. And as I mentioned earlier, I think a simple place to start with that is a chart review. So if a resident presents a patient that they've seen in clinic that day, asking the clinical clerk or the medical student other questions they may want to ask. So it's kind of a group facilitation, really. Everybody's collaborating and engaged and kind of chiming in with answers. So yeah, no, there's certainly great methods to do those things.
And just a reminder to the group: when we talk about targeting, we are talking about the appropriate targeting of learners in terms of targeting the question, and not sort of, pointing out to people their gaps and their deficits. So it's a great term that we took from the literature we reviewed, but Lynn and I recognize that it can have some slightly negative connotations. So we want to mitigate that. That sense that we are putting someone on the spot. The goal of layered learning is to, in fact, get the team to teach each other. And the literature suggests that when we do layered learning well, we actually create a learning environment that's much more supportive for individuals who have gaps in their learning.
And certainly much more respectful and non-targeted in the alternate meaning of target. Next slide, please. So novelty is simply discussing a newly published article, or it may be a hot topic or a new clinical practice guideline. I like to use this kind of as a homework. So I often will give, the medical students or residents a suggestion that, if they've heard about something new, read about it and come back and tell the group about it tomorrow. Or if it's a new clinical practice guideline, perhaps we all will read it and kind of discuss it as a group the next day.
And I think, Lynn, with novelty, what we've seen in some of the examples in terms of taking some of the concepts of layered learning and moving it outside of the preceptor's office, that is often what we are doing when we have residents leading PBLs, when we have residents chair team meetings, when we do other things that feel less like they're happening in the purely clinical environment, but are actually moved to sort of that more didactic or non-clinical environment. So I think that there's, again, some opportunities to think of all of these techniques as ways that we can expand beyond just the clinical setting.
I agree, and I think we use a lot of these techniques already. We just don't label them with some of these terms, perhaps. Next slide. So progressive questions is also referred to as up the ladder in the literature. And basically, you ask the same question of a medical student and then a resident. And it's really important to be mindful that some students may have a stronger knowledge base than residents. And if we all think back to residency, I mean, we were what we're studying for exams may not be certain minute detail around pathophysiology and things that you learn in your first and second year of medical school. So as an example, if I was to ask some of my learners what are some of the presenting symptoms of myasthenia gravis, the residents are further removed from that teaching in the medical school environment. And the first and second and third year medical students would probably quickly talk about the acetylcholine receptors and the presenting symptoms and the tests to rule it in, rule it out. And in some ways, I mean, this is great in that it gives the medical student an opportunity to be more confident and feel competent and really contributing to the team. But at the same time, it's really important to be respectful of how we do this and not to make the resident feel less because they didn't know it.
I think that again, like targeting, progressive questions need to be conducted in an environment that really is supportive of layered learning and of learners admitting where their gaps are. It's really important as we ask questions moving up the ladder that we recognize that all of us, including the faculty as expert, has gaps that we need to identify and model as part of our lifelong learning. And I think that's been an excellent point that's been raised again in the chat about how we can do that in a way that, and ask these progressive questions that make learners feel that, again, we're learning as a team rather than attempting to expose gaps.
Mm-hmm. Absolutely. Next slide, please. And learner as the teacher. So different layer of learners can teach other learners. And I think that's important to help in multiple ways. One is to allow everyone to be a teacher, but the other is perhaps your medical student is really skilled at certain parts of clinical exam. So asking them to demonstrate for the resident how they would examine an abdomen, maybe confidence building as well. So as our examples indicate, so our M4 can show the M2 how to examine for ascites, or the resident can show the medical student how to do a ring block of the toe and then do a wedge resection of the nail. And teaching as they go, but then asking the medical student to perhaps do it the next time under their supervision.
I think that, again, these are opportunities as well to reinforce the learner's continued role as a teacher, and to start to build that capacity of our learners to recognize that when they complete their time learning with us, that they may well be moving on to other roles. And our expectation should be that every learner that we train will have the capacity to emerge from our training programs as teacher ready, able to take on the challenge of having students, whether or not they've actually sort of been prepared to do this. And I think that, again, creating all of our learners as teachers really allows us to do that. And what it also does is one of the things we often do poorly in medical education, which is help reinforce for learners things that they do well. When you ask someone to teach something to another person, you're often targeting particularly a clinical skill that they're quite competent in. And I think that sometimes we forget to provide feedback to learners about what they do well, and having them teach their colleagues can be an excellent way to provide that feedback about what strengths learners have been demonstrating.
That's a really good point. And in the chat box, someone mentioned earlier, Dr. Kapolu and Dawood mentioned about having our role as facilitators more so than perhaps preceptors, but we're facilitating the learners in teaching themselves. Obviously, mentoring, guiding. Someone else mentioned in the chat box as well about getting the residents to chair team meetings as a leadership learning event. And I think that's a really great idea. Next slide. Oh, go ahead.
I was just going to say there's been, again, while you were speaking, some wonderful additional comments about the real opportunity to use this in, having residents from other healthcare professions involved in teaching medical students and medical residents, and an opportunity to share different perspectives that each of us from different healthcare professional domains bring to clinical care. So I didn't want to lose that thought.
And I guess to follow up on that thought, just brought to mind an example which I thought was a mutually respectful and kind of rewarding someone for recognizing a great skill. So we've layered learners with nurse practitioner students, and nurses have a different skill set for the practical things than physicians. The EKGs, the intravenous's, the catheters, all those kind of things that us as medical students, we are probably not as skilled as a lot of the nurses. And so when we were training our nurse practitioner student, we engaged her as well to kind of help with some of those teachings. So I think she felt to be a better, more value to the team, and certainly was confidence building for her. The final topic or method is teaching to the top. So really, in this case, you just teach to the most senior level on the team. So asking, your senior resident what would be the next thing to try in heart failure for someone who's already maxed out on ionotropes. Or, and if they don't know, I mean, it's okay to, you can ask the medical students if anybody has any thoughts or ideas. Perhaps the medical student had just done a critical care elective, or, asking their opinion is always important. The other example that we have listed there is for an R2, asking what drug they may consider in a palliative patient who has retractable nausea. So we've already tried metoclopramide and ondansetron. So really kind of challenging questions where we start at the top, but certainly would go down the ladder and ask people's opinions.
So these are our 6 strategies that we've evolved from the literature around where we can probably group most of what we do to address layered learning. Lynn, I think this would probably be a really great time to take a look at the chat and answer any questions related to what's gone on so far. One question that I did see that came up related to the question of continuity, and whether continuity in the relationship and the members of the group plays any role in layered learning. Certainly from our review of the literature, that did not come up as a factor that supported layered learning. However, we do know from some of the from the other educational literature, the group that I'm most familiar pertains to longitudinal integrated clerkships, that one of the strengths in those learning environments has been that ongoing continuity or arrangement of learners. And I think that speaks probably to the continuity of person and the continuity of place in terms of the learning environment. But I think it also speaks to the fact that because continuity of person and place contributes to developing a learning environment that feels safe and where people can trust that they can be free to make mistakes and learn from them. So I think that absolutely continuity would play a significant role in the development of that trust. And certainly we know that one of the factors that has been identified in successful layered learning environments has been the development of that supportive learning community.
So one of the other questions kind of follows through on one of the teaching methods was, have you had experience with the younger learner knowing more than the older learner or more senior learner? And I mean, that happens a fair bit. I mean, really, I've encountered it with around medications and stuff. So a brand new medical student, but they've been a pharmacist before. So people's backgrounds, the schools they're coming from, sometimes the international medical graduates are part of our layers. So people's backgrounds really do impact. And certainly, if we see an interesting case, we remember it forever. And one of my most vivid memories as a medical student, and it was a negative encounter in the sense that the I had a family member who had Lofgren syndrome, which is a subset of sarcoid, and we were in clinic, and the resident was asked what he thought the red spots were on the lady's legs, and he wasn't sure. He asked if they were phleboids, and so I was then the most junior learner, and I was brought in, and and I said it looks like a form of sarcoid, and I asked her questions. She had a cough and things, and it was certainly the resident kind of laughed and called me smarty pants, but I just said, well, I had a cousin who had it, so I kind of remembered the features. So sometimes if we have a clinical encounter that sticks with us, we may appear to be really smart with a certain topic. So, but the preceptor was very condescending to the resident, and it was a rare thing. And so I think how we handle those situations and the environment we create for layering is super important, because those scenarios will happen. How we handle them, though, should make it to be okay, that it's okay that the junior learner knows more in this particular case.
Yeah, that's great points, and so common, Lynn. Another question that's been asked is, how do we encourage it in areas where you have fewer learners? For instance, in rural environments where there might only be a medical student, and there are not necessarily residents. And I think that really speaks to some of the wonderful chat that we've had going on in terms of some suggestions on how to address this. We can start to use some of the facility we've developed in virtual learning to actually use that as an opportunity to layer our learners. I think thinking beyond medicine itself and what are the other individuals who are learning, even if they may be individuals in active practice. So how do we integrate our students to learn with other healthcare professionals, other physicians within the community, and bring them into that fold where there are multiple layers. So I think that it is challenging when you're at a site where there might only appear to be one layer of or there might appear to be only one layer of learners, but in fact, the reality is that if we expand our way of thinking around this, we often can find multiple layers. And certainly the idea of thinking about doing some of this virtually, particularly in non-clinical situations and didactics, I think is a really great way to build in layering when layering is difficult to find.
And I think really key here is, in a lot of the rural settings, and I practice in a rural area, and there are at times one learner here, sometimes two medical learners, but there's often nursing students. There's, so if we're doing assessment things, or there's a neat thing on a neat EKG change that we're going to teach, then, we try to bring in all the learners we can. And, for inpatient rounds, there's often pharmacy students, or so there's using allied health, I think, is very important. And I think, again, that, reinforces the idea of collaborative care. And that's something that as family docs we're really good at. And I think the quicker and the sooner in training we let students see how well we do that, I think the better.
I think another question came up about sort of tips to doing this in the virtual setting. And I think one of the things that we are learning about with more and more of our work and some of our clinical work being virtual is the need to be thoughtful about how we are doing this, and thoughtful about thinking about how the layers might work. with a student seeing a patient virtually, discussing it with a resident who's in the virtual environment, and then reviewing it with a faculty member who's precepting them. I think there are some opportunities, but like everything in this era that has led us to this rapid shift, I think it's incumbent on us to really be, very thoughtful about how we do this, and then to experiment and share what has worked well and what has not worked well, as we've tried to layer our learners virtually as well as geographically.
And the virtual, I think we'll see lots evolve in the upcoming months, I believe, because, as I said earlier, the undergrad students are back in clinical practice, some schools already, and most rolling out by July. So there will certainly be lots of interactions with residents and clerks for sure in virtual environments. So it would be interesting to have a discussion in a few months to see, how things are going and what's working well and what's not. Someone also asked the question, pitfalls to avoid. And I think the biggest pitfall for me has been to ensure the residents' engagement, because majority of residents want to teach and are engaged in teaching, and it's part of residency. You're a senior resident on perhaps internal medicine as the family medicine resident, and you have maybe 2 clerks who you're responsible for. So, inevitably you're teaching. Some enjoy it more, and some are totally engaged, and others are a little disengaged. And the success of how well that layering goes often does depend on that. So really important to kind of scope out where, how keen your resident is on teaching and what their experience has been. And as Lisa said earlier, if there are things that we should do as preceptors to help kind of make them feel more equipped to do that, rather than kind of just throwing them in.
And I think it's really interesting, Lynn, because I think particularly some of our early residents often don't realize how much they have learned over the course of their medical education in med school. And I think sometimes it's really great to be able to signpost for early residents just how far they've come in terms of what they know. So I think I agree, it's really worthwhile to explore with the disengaged resident where that disengagement is coming from, because so often it feels like it may be related to anxiety about their own knowledge base, anxiety about their ability to teach. And again, if we can help our learners understand that feedback and learning from someone who has a near peer, someone who's recently been through the educational experience, is an incredibly powerful learning technique, and often sometimes more powerful than sometimes some of the things we think we're doing as faculty and doing well. Mm-hmm. I think that layered learning really allows us to start to play around with that conceptually. But I agree, we need to, with our reluctant learners in their role of teacher, I think we really do need to explore where those gaps are coming from and how we can support everyone to continue to enjoy teaching.
Mm-hmm. And on that note, I wanted to make a plug for the section of teacher resources. So on the college's website, there are lots of great teaching resources under the section of teachers. And as well, I believe there's some links that are posted in the chat box to these resources as well. And don't forget your survey.
And we've also created a one-pager that hits the high points of what Lynn and I want to make certain that if we said nothing else, we made certain that we conveyed this today. So that's been prepared for you and is available again through the web link. Shall we go to the next slide, Lynn?
Sure.
So we just wanted to put in a few concluding statements, what we think we've done, and hopefully we've been successful. We think we've actually given everyone a good definition of what layered learning is about. We've had an opportunity to really identify the challenges and the benefits of layered learning. And Lynn and I, as well as all of our contributors in the chat, have really provided some really great tips for integrating layered learners into teaching. And I've got a couple of points that I will add to the next time that I talk about layered learning that comes directly from the chat. So we thank the contributors to the chat for their robust discussion.
Mhm.
Um,
Excellent. And so if anyone has any other questions or comments, please make a note in the chat box, and Lisa and I will do our best to address.
Lynn and I are allowing for, we understand there's a 10-second delay from when we speak to when you may hear us. There's one question about doing this in the virtual setting. Absolutely. If you can do this, some of the web-based platforms will allow more than one person to be on the virtual visit. If you're using a standard telephone, you may actually need to put people on a speakerphone. And that's probably something different from what we normally do, but again, a really great opportunity to, again, practice not only having the patient on the speakerphone with two learners, but potentially actually expanding it to understand that eventually we'll have the patient and the individual who normally would have been in the office with them also on the phone call as well. So I think there is an opportunity to start to think about how do we do this in the virtual world. I think we don't know some of the answers to the questions we'd love to have the answer to. How many learners is going to be too many on a virtual visit? What's the optimum number? What is the best arrangement for layering? Are there any technology modalities that are really well suited, particularly in clinical environments? Those are great questions to which I can posit some answers and suggest that we really need to be thinking about how do we continue to translate what it is that we are doing in the clinical setting in person into the virtual world.
So one of the things that I've done in my clinical practice over the past few weeks when I do most of my virtual visits over telephone, I've asked my patients, would they mind if a medical student call them first? The medical student would then discuss the case with me, and then we would both call them back together. And the vast majority have been really receptive to this. And so as we are ready to move the undergrad students back into clinical settings, I've kind of been trying to figure out, okay, how can I make this as robust a learning experience for the learner? And then as well, figuring out how the resident who will be starting in my clinic in July will be incorporated into this. So I think if we think outside the box and patients are surprisingly agreeable and recognize the challenges that we all face. Most of the patients in my practice would have seen a medical student before, so it's not something new. Certainly not all the problems that we deal with over the telephone are very easily dealt with, but certainly knowing ahead that it's a follow-up of a diabetic checkup or things like that, I think it would be fairly easy to be able to engage an undergrad learner and even have the resident, as Lisa mentioned earlier, supervise or facilitate that encounter.
So Lynn, I'll ask you a question from the chat. Have you ever felt that you need to listen into that phone call when you have the student call the patient first, or how do you manage that anxiety?
So I actually thought about that, because certainly if it's a brand new learner to me, my plan, because I anticipate this in July, is to have them sit in with me on some virtual visits first. And I would just say to the patient that the medical student is in the room with me, and able to hear our conversation. And so they would have an idea as to how a virtual encounter over telephone will go. But and yeah, I mean, I think part of how we, I guess, mentor and supervise and facilitate is by watching. So I agree. I think some of those visits, it would be a good idea to listen in.
Yeah, great. I appreciate that
That's
clarification.
very anxiety provoking, though, to students as well, because I remember my first few virtual visits, and I thought, this just seems really weird. I'm asking them questions when they should be seated in front of me, and it seemed so impersonal. But months in now, we're all getting used to it, and I think to a certain extent, for a lot of problems, patients find it better, because if you live in a rural area like I do, some of my patients travel an hour and a half to get to me.
But what a great way to create a supportive learning environment. And I think that happens when you have layered learners, because we start to talk about things that we find challenging and difficult. And then learners share that, and we look for solutions together. And I think that's one of the key things to layered learning, is that, again, supportive learning environment.
Mhm.
So Lynn, I think we may have come to the end of the questions and the end
Mhm.
of our webinar. And I think this is the point in time where we want to make certain that we thank everyone who helped pull this together, and to thank our participants for a really vibrant chat that we've really appreciated. Someone said they felt like we were in their kitchen, and I'm glad we've been able to invite them into the dialogue that we've been having over the past few months about what is layered learning.
Mhm. Thanks so much.
Thank you, everyone.